Welcome everyone to another episode of Office Hours, where we explore the latest challenges, developments, and innovations in the healthcare revenue cycle space. I'm your host, Stuart Newsom, Vice President of Marketing at Infinix. My guest today is Julie Graham, our Senior Coding Manager. And as you can see from today's topic, we're going to discuss mastering reimbursement challenges in cardiology coding. Now we're going to delve into these challenges of coding, in particular the issues around bundled payments, because it's obviously can't cover all aspects of coding in this short period of time. But I'll tell you, Julie probably knows all about all that as well. But bundling has been around for several decades now, but it still causes plenty of problems that affect denials and revenue and reimbursement. So even though our focus today will be on cardiology, we will discuss principles that could also apply to any specialty out there. So Julie, how you doing today?
I'm doing well. Thank you, Stuart.
Awesome.
Happy to be here again.
Yeah, awesome to have you with us. So we'll just dive right into this. I know just asking if you could give us sort of an overview of why bundling codes is a common practice in cardiology coding and how it impacts reimbursement. I know there may be some people out there who already know this, but it's always good to kind of lay the groundwork.
Yeah, absolutely. So basically, in a nutshell, bundling streamlines the billing process. It reduces administrative costs and ensures accurate reimbursement. And bundling is often done for several reasons. And some of those critical reasons are to account for services that are routinely performed together or ones that must always be performed together. Two, for complex procedures involving multiple components. So think about on a bigger level, your cabbages and cardiothoracic type surgeries. And then three, to streamline the billing and avoid submitting multiple claims and to ensure proper payments. Now, the drawback to bundling, as we all know, as coders and AR and managers alike, and everybody in the trenches, this often does lead to reduced reimbursements because of the bundling of all those codes. So, yeah.
Yeah, it's definitely an ongoing problem. And like I said earlier, I think I remember 1996 when the Correct Coding Initiative came out with those bundling and unbundling. And it definitely has been a weight on everyone's shoulders for all these decades, but it's just always ever changing. And typically with Medicare and OIG guidelines. So what are the most critical aspects of Medicare and the OIG guidelines that coding professionals need to be aware of when dealing with bundling
Yeah,
cardiology procedures?
I'm sorry. That's a great question. So I as coders, you have to look for CMS, you need to look for your LCDs, your NCDs, and even utilizing the NCCI policy manual. And I'm going to be attaching some links here into the chat in a minute that Stuart will share. So the LCD is important for coders because the LCDs tell them, there's a lot of great information in there. It'll tell you can't bill these codes together, or here are the ICD-10 codes that support medical necessity for a certain procedure. But the information in there will often will glean information and understanding into why you can't bill something or things that cannot be billed together. The NCD is another one. That's your national coverage determination. And then the NCCI policy manual, which has a plethora of information on the way that CMS sees certain procedures, why things can't be billed together. So those are really good resources for coders to be aware of. And let me drop a couple of those in the chat now. I'm going to add I'm including the MCD search because this link that I'm about to share will give coders, like if you don't know, if you don't know if there's an LCD for a certain procedure, you can actually go to the website that I'm about to drop in here, and it will give you a list of all of, I don't think that came across correctly. It did not, and I apologize for that.
Right. We may have limitations on doing chat to
Okay.
the
All
whole
right.
audience. Oh, there we go, to everyone. Now I see it's turned on.
Oh, it is. Okay, good. Well, so the MCD search will allow you to go in there, put in a code, and you can find any LCD related to that. If you're not aware of your MACs, there's you can go and search up MACs, so you can find all that information, by state, by MAC, what your MAC covers, Part A, Part B. So yeah, that's good resources for coders to utilize to understand when you're dealing with bundling of cardiology procedures. The second one is the OIG Active Work Plan. And so the OIG Active Work Plan, it reflects what the OIG audits, evaluations, and inspections that are underway or are planned. So you can go to their website and, do a search for that. We know that Modifier 25 is constantly on their list. So just those are things to be aware of. And then the most important thing when we're talking about bundling procedures related to cardiology is to establish medical necessity for those procedures where you can carve out the bundling edit with a modifier. That is so important because there are edits that allow for multiple procedures or to be billed together, but there are specific guidelines and certain circumstances that you have to follow to meet that modifier. So that's definitely a point that coders want to be aware of.
Right. And everything you just mentioned changes at a certain cadence.
Yes.
Right. So you have your
Yes.
like CCIs every quarter. Your LCDs and NCD policies may change, who knows? I mean, monthly, even more frequent.
Exactly.
So it's important to keep up with those changes. It's not just like ICD-10 where it's once a year, which ICD-10 may change twice a year now, or CPT as well. It's much more frequent.
Yes, absolutely.
So in the specific case, just give us some, I guess, some examples. I know one example that you and I discussed was the case of an endomyocardial biopsy when it's
Yes,
being
sir.
done with a right heart cath. So what are the limited circumstances, just as an example, where both can be reported, and how does this align with Medicare and the OIG guidelines?
Okay, yeah. So I think one thing that's important that coders can also look for is when did a bundling edit become effective? So when I go and look at the NCCI edits between the endomyocardial biopsy and a right heart cath, your 93505 and 93451, we see that NCCI edit became effective on January 1st of 2011. So prior to that, you could bill it. After January 1st of 2011, these procedures are now bundled. And I think that's important for coders to know because, as you know, the healthcare landscape is constantly changing. Those bundling edits are constantly changing. So what you were able to do last year, you may not be able to do the following year. And so knowing that effective date will help you ensure that you're coding correctly and in compliance. And so when we're talking about this specific case of a biopsy with the right heart cath, we have some direction from the OIG. And the OIG states that right heart cath 93451 may be coded, but only when a complete catheterization is performed for separate medical necessity unrelated to transplant rejection evaluation. The OIG considers a right heart cath to be inherent to a biopsy procedure with a few exceptions. And per the OIG, we would expect to see this code combination less than 10% of the time. So that kind of gives you an idea of you can't really skirt around this all the time. It's going to be a very minimal, very specialized clinical indication, clinical situation that you're dealing with. And so then we look to the LCD L 30719. Now this is specific to my area and I'm in Houston. So Novitas, that area. And so what the LCD says is that 93505 may be separately allowed when performed independently or in addition to a cardiac catheterization procedure when medical necessity is met for these three reasons: a pre or post heart or lung transplant, suspected doxorubicin myotoxicity in the presence of or suspected heart neoplasm. So those are three very limited circumstances. I've never coded for any of those. I've never even seen any of those. But we do see that these are the limited circumstances that would report medical necessity of reporting the right heart cath with a biopsy. And so if the patient's clinical indication is supported by any of those three up there, then yeah, make sure your physician is aware of that and make sure that that is clearly documented within their procedure notes. So that because chances are these, it's going to be audited, or not audited by the insurance, but they're going to want to see medical records. And so you want to make sure that your documentation is going to support that. Another note here is that the OIG has not addressed endomyocardial biopsy with left heart cath. So like your 93454, 93458, 93460, there are no NCCI bundles when you're trying to build those with a 93505. And so we have actually been successful when those two procedures are performed together, getting those claims paid. Now I know that Dr. Z kind of warns against the 93460 because it does include a right heart cath. That's a right and left heart cath. He actually suggests to just report a 93458, but again, we've had success reporting that 93460 with 93505.
Nice. And I guess it also depends upon which payer you're submitting this to as well. I know this is primarily,
Yes,
Medicare, but payers may have their own rules, especially with these limited circumstances involved. So,
absolutely.
and you hit on something that I just remind everyone all the time is documentation. Documentation just rules everything. Even though you may bill it and dictate everything that you just advised, the most important is if they come back and all of that, if it's not documented, then this just never happened. I know everybody realizes that, but it's just always good a reminder because it's always something that comes up. It seems to be that you see these cases where this documentation has failed to be present, and then they
Right.
had to either recoup the money that was already paid, or get denied outright. So
Mm-hmm.
before I move to the next question, I failed in the beginning to tell everyone that there is a Q&A. So if you click on the Q&A box, you can actually put in a question that you have that you want to ask Julie or myself, and we will cover it for you. If we don't know the answer right off the bat, then we'll find the answer and send it to you afterwards. But please, I encourage everyone to utilize that Q&A, and we'd love to hear from you. So Julie, lastly, I just want to say, ask you, how important is auditing and ensuring compliance with bundling regulations, and what best practices can you suggest? That was kind of the segue we had from the documentation comment that I had.
Right. Well, and going back to what you said about documentation, I think it's also important that, insurance companies, payers specifically see those that clinical indication, not only in the procedure note, but also in the evaluation and management. I'm thinking from a coding perspective, if, it's never been documented before in any E&M, and you're just now, you're just slapping it into the op note, insurance companies may want to see a little bit more substantiated evidence of that medical necessity. And so that's why it's so important that your evaluation and management documentation, focuses on what's going on with the patient and is carried over and it's followed up on, and to make sure that all of that is documented to support those procedures going forward. Just wanted to add that little tidbit. So when we talk about, auditing, it's extremely important. Auditing allows you to identify potential pitfalls, where your practice may be out of compliance with regulatory standards. And the audit also serves as a tool to identify potential loss of revenue related to undercoding. The positive side effects, if you will, are decreased expenses and preventative measures that help improve clinical documentation in the ever-changing landscape of healthcare, as we all know how quickly it changes. And the cadence, when you talk about, when should this be done? How should this be done? So the cadence and scope of audits will, be based on several factors. However, the Department of Health and Human Services requires that at a minimum, you do an annual audit. That's a minimum requirement. And so from there, if you find a specific problem area, you obviously want to, a cadence that is more frequent than once a year, because you want to have with any audit, you want to have a set objective and a goal, something from which you can go back and say, hey, this is what we were looking for. We provided this education. We did this. Now let's go back and see, let's review some more records. Are we still having the same issue? Do the providers need more education? Do the coders need more education? So yeah, it's, you always have to have that. You don't want to just go into an audit blindly and just, well, we're going to look at everything we've ever done. No, you really need to have a scope and a focus on that audit, because it just keeps things it keeps things tight and prevents you from kind of going all over the place, because you can go down the rabbit hole real quick.
Right.
Another procedure that I see sometimes where doctors don't always understand is codes that are listed in CPT as separate procedure. So I have seen where physicians are not aware of this, or maybe even some young coders aren't aware of this, and they want to report like a temporary pacemaker, 33210 with, a heart cath. Well, you can't do that. If you look in CPT, it's a separate procedure. And the thing about that is separate procedures, like it's inclusive of any procedure that's closely related to or directly related to it. And so the only time that you can bill that separate procedure is if it's the only procedure done, or if it does not relate to the main thing that's being done at that visit or during that procedure. So but if you look at the NCCI edits, you don't have to guess on this. So if you to go to NCCI edits and you pull up these two codes together and you look at how the bundling edits are, there is no way to override this. There is no modifier that overrides a heart cath with a temporary pacemaker, because it is related to that heart cath. So there is no room to use a modifier.
Right.
I should say no concessions to use a modifier.
Right. Concessions. Exactly. Well, wow, that's a lot. We covered a lot in 20 minutes. So you could do a deep dive in any one of those things: medical necessity, auditing. There's so much material that could cover hours and hours, but trying to pack it all here in 20 minutes. But just wanted to open it up to Q&A right now.
Okay.
And so we do have one question here, and it's what are some common areas you see compliance issues in your audits?
Recently, I saw where the documentation for central venous line placement, like a 36556, 36558, the catheter has to be documented as residing in the IVC, the subclavian, and one other area. And I'm sorry, I can't think of it off the top of my head right now, but if that catheter is not, if the doctor does not document that that catheter is in that area, then you can't bill that code. And, I had a provider that was just saying, oh, CVC placed at the request of anesthesia. And so it's like, well, where's the medical necessity for that? And then from there, he would put it in under procedures performed, but not within the report. So that was an area. Telehealth, another big area that I see where the documentation isn't supporting that synchronous audio video. Like it'll just say that the patient was seen over a telephone call, or it was over a telephone call or something like that, or the patient didn't give verbal agreement to do that. So those are some areas that I see. Yeah, and on top of the other ones I discussed today, those are the two that jump out at me immediately.
Awesome. Well, and I do have a question here as well. With the continuous evolution of medical procedures and payer requirements, what future trends do you foresee in cardiology coding, and how can coding professionals prepare for these changes? And Julie, maybe we can tag team this, but I know that's kind of that's an overarching question that can cover a lot of aspects.
Yeah.
So yeah, go ahead.
I know that Dr. Z has talked about some potential changes to lower extremity revascularization codes. I don't know how exactly those will be impacted. These codes have already been bundled. They've already bundled the cath placements, the SNI. And so I'm not sure how those would be, but I think coders and coding managers, coders, directors, AR, they can stay abreast of these changes by attending webinars that educate you on changes, upcoming changes to CPT. The environment, the technology is always changing. I mean, last year we had to use a T code for intravascular lithotripsy, and now it has its own code. So little things like that, but it's always going to be through continued education, making sure that you're staying abreast of those. And that's the best I can give. I don't know off the top of my head what changes are coming down the pipeline for cardiology at the present moment.
Yeah, I think you nailed it on the head there at the end there. It's going to depend upon technology. And as technology advances, because it's amazing. I mean, especially everyone's talking about AI and automation,
Yeah.
particularly in software, but it's
Yeah.
also there in like medical devices and robotics and certain aspects of that. So as that starts to develop in the future, you can tell it's going to be some advancements, not just in coding, but also how it's documented and how it's billed. So, that's
That
the,
is it.
yeah, go
Oh,
ahead.
sorry. No, that's an excellent point. And I just want to let any coders out there know, AAPC was offering a free course to kind of educate us on AI. It is it is for a certificate, but AI is big right now. It's taking over. I have not utilized AI in coding yet, so I'm a little timid of it. I'm not sure how it works, but I have signed up for the course. Like I said, it's free for members. So if anybody's interested in that, that's definitely
Mhm.
something that will be coming down the pipeline and will affect every specialty.
Right. Yeah, absolutely. Absolutely. And if you want to know, I did a little office hours on AI about 2 weeks ago, our episode that was aired 2 weeks ago. You can find it on our website. And it was really where I did a summary of what I learned at the HIMSS conference as well as the Alabama HFMA conference, and both of those focused a lot on AI. So there's a lot of
Yeah.
information that was covered in that office hours as well. So I encourage you to go back and watch that.
Yeah.
Wasn't very long. It's just about 30, 35 minutes long.
Yeah.
All right. Well, we don't have any more questions, Julie, and
Okay.
I think we can wrap things up. I really appreciate you. I want to thank you again for joining us. We're going to see more of you.
Yes.
So just a little sneak peek for everyone out there. So if you enjoyed today's episode, be sure you join us in about 2 weeks or so, where Julie will be back and we'll talk about some more coding subject matter. And so with that, I appreciate everyone joining us today, and be sure that you sign up for next week's office hours as soon as it's published. Thank you very much.
Thank you.